Welcome back to IMG Doctor Diaries. Before we get into today's video, if anyone is planning to sit the MSRA for the next training application window, make sure you check out Revise MSRA. It's a really useful resource for revision, and you can get 10% off using my code IMGDSEP10. Now, in today's NHS On-Call Survival Series video, we're covering back pain. Now, back pain is one of those presentations you will get called about quite a lot on call. And most of the time, it may turn out to be something more routine, like a strain-related or non-specific spinal pain. But the reason this topic matters is because sometimes back pain is a sign of something much more serious, and your job is to work out which is which. Because yes, it can be a more routine musculoskeletal problem, but it can also be cauda equina syndrome, vertebral fracture, spinal infection, malignancy or metastatic spinal cord compression, or even something outside the spine completely, such as an abdominal aortic aneurysm or another abdominal cause. So in this video, I'm going to take you through a practical on-call approach to back pain, including the important causes, the history, the examination, the investigations, and the initial management. So when you get called to review a patient with back pain, the first thing to say is that the order of your assessment depends on how stable the patient is. If the patient is stable, you can often start with a focused history while also checking the observations, looking at the drug chart, and getting an idea of what is going on. But if the patient looks unwell, has abnormal observations, or the story immediately sounds concerning, then you should go straight into an A to E assessment. And in real life, these things often happen alongside each other. Because if someone has back pain, but they are hypotensive, tachycardic, sweaty, confused, or looking very unwell, then you need to think beyond a simple spinal cause and deal with the immediate problem first. So yes, back pain is the presenting complaint, but your job is still to assess the patient safely and work out whether this is routine back pain or whether this could be something more serious. How to think about the causes. Before you even go into the detail of the history and examination, it helps to organize the possible causes in your head. One group is the more common non-specific or strain-related spinal pain. This is often linked to movement, awkward positioning, chronic degeneration, or a flare of pre-existing pain. Another group is radicular or nerve-related pain, where the pain radiates, often down the leg, and may suggest nerve root irritation, usually from a disc problem. Then you have the more serious spinal causes, and this is where your red flags matter most. This includes things like cauda equina syndrome, vertebral fracture, large central disc prolapse, spinal infection, malignancy, or metastatic spinal cord compression. And then finally, do not forget referred causes. Not all back pain is actually coming from the spine. Sometimes it may be coming from the aorta, the kidneys, or another intra-abdominal pathology. So your job is not just to hear the words back pain and assume it is simple. Your job is to ask what type of back pain this sounds like and whether anything here sounds dangerous. If the patient is stable enough, a focused history is one of the first things that helps you narrow things down. Start with the onset. When did it start? Was it sudden or gradual? Then ask about the duration. Has it been there for a few hours, a few days, or much longer? Ask whether they have had previous episodes before. Then ask about the site of the pain. Is it lower back, thoracic back, central, or one-sided? Then ask about radiation. Is it going down the leg, into the buttock, around the flank, into the groin, into the abdomen? Ask about the severity and how much it is affecting movement and function. Then ask whether it is related to movement or position. Is it worse on standing, sitting, bending, turning, lying flat, coughing, or straining? Then move quickly into the important red flags. Ask about trauma. Ask about weakness. Ask about numbness or paresthesia. Ask specifically about bowel and bladder symptoms. This is really important. Any urinary retention, difficulty passing urine, loss of urinary sensation, incontinence, reduced awareness of bladder fullness, bowel dysfunction, or saddle numbness should make you think seriously about cauda equina syndrome. Ask whether the symptoms are bilateral, because bilateral leg pain or bilateral neurology can be more concerning. Ask about difficulty walking or legs giving way. Then, depending on the case, also ask about fever, weight loss, night pain, history of cancer, immunosuppression, 1V, drug use, recent infection. Because these start moving you away from a simple strain-related explanation and more towards infection, malignancy, or cord compression. So, by the end of the history, you should already be thinking, does this sound like a more routine spinal pain? Or are there red flags here that mean I need to escalate this quickly? Now, before I go through this part, I just want to say that I will make a separate full video on the A to E assessment itself because that deserves its own proper breakdown. But for this back pain video, I want to focus on the parts of A to E that matter most for this presentation. So, if the patient looks unwell or the observations are concerning, then you should be going into an A to E assessment straight away. And even if they seem stable, A to E still helps you work out how unwell they are and whether this is actually something more serious than simple back pain. A. Airway. Starting with A, the airway will usually be fine in a back pain patient, but you still need to assess it. Are they talking normally? Are they alert enough to give a history? Because if they are drowsy, confused, or not engaging properly, then you need to think more broadly. Is this sepsis, shock, or oversedation from analgesia? B. Breathing. Then with B, look at the respiratory rate, saturations, and work of breathing. Back pain itself should not usually cause major respiratory compromise, so if the patient is hypoxic, tachypneic, or looks very breathless, then something else may be going on. Are they splinting because of pain? Could this actually be chest pathology? Could this be something more serious like PE or even aortic pathology? C. Circulation. C is a really important part of a back pain review. Check the pulse, blood pressure, temperature, cap refill, and whether the patient looks pale, clammy, or shocked. Because if someone with back pain is hypotensive or tachycardic, that is a red flag. That should make you think about things like AAA, bleeding, sepsis, or another serious cause rather than routine spinal pain. This is also where you should review the drug chart. What analgesia have they already had? Are they on anticoagulation? If there has been trauma, especially in an older or frail patient, that becomes very relevant. And this is also where you should start thinking about the abdomen. If there is abdominal pain, tenderness, guarding, distension, or any concern for a pulsatile mass, then widen your differential early. D. Disability. Now for back pain, D is one of the most important sections. This is where a lot of the major red flags sit. Start with the basics. Are they alert? Are they confused? Are they in severe distress? By this point, you may already have asked about important neurological red flag symptoms in the history, such as weakness, sensory change, saddle numbness, and bowel or bladder dysfunction. Now, the key thing is to examine for any objective neurological deficit. So this is where you do a proper lower limb neurological examination if there are any concerns. Check power in both legs. Check sensation. Check reflexes if needed. If the pain is radiating, assess straight leg raise as well. And if safe, look at gait. Can they stand? Can they walk? Are they clearly weaker on one side? So in the disability section, you are really trying to work out whether this is routine pain or neurological compromise. And if you are worried about cauda equina, do not be falsely reassured by one normal finding if the overall history is concerning. E. Exposure and examination. Then in E, expose enough to inspect the back properly. Look for asymmetry, abnormal posture, bruising, deformity, or evidence of trauma. Feel for midline spinal tenderness, because that becomes important if you are worried about fracture, infection, or malignancy. If appropriate, assess movement, but do not force it if fracture is a concern. And again, do not forget the abdomen. If the story is atypical or there are abdominal symptoms, check for tenderness, guarding, distension, or anything that makes you think the pain may not be coming from the spine at all. Investigations and management should happen hand in hand and be guided by what you are worried about from the history and examination. Review the drug chart properly, especially what analgesia they have already had and whether they are on anticoagulation, particularly if there has been trauma. If there are urinary symptoms or concern about retention, then do a bladder scan. If they are in retention, catheterize if needed, but also think about the underlying cause, especially cauda equina syndrome. Bloods may include full blood count, UNEs, CRP, ESR, clotting, calcium, phosphate, and ALP. And if the picture is concerning, a myeloma screen as well. Imaging should be targeted. That may include a spinal X-ray, an MRI spine if you are worried about cauda equina, cord compression, infection, or significant neurology, or a CT if there is suspicion of fracture or another serious cause. If the story sounds more abdominal or vascular, then think about ultrasound abdomen or CT abdomen, depending on the concern. At the same time, manage the patient with analgesia. Involve physio where appropriate. Immobilize if fracture is suspected, and seek urgent senior support early if you are worried about a serious cause. I know this has been a slightly longer video, but hopefully it has given you a clear and practical approach to back pain on call. If you found it useful, make sure you like, comment, and subscribe, and let me know what topic you want me to cover next in the series. Thanks for watching, and I'll see you in the next one.